My name is Michelle Nduele, and I'm the Senior Director for Health Promotion and Quality of Life Strategies with the Arthritis Foundation. It is my pleasure to talk with Dr. Tonia Vincent. Dr. Vincent is the Director of the Center for Osteoarthritis Pathogenesis, a professor of Musculoskeletal Biology, and a consultant rheumatologist with Oxford University. She has co-authored several articles about osteoarthritis, including topics such as cartilage repair activity, estrogen-containing therapy for hand OA, peripheral pain in OA, and exploring the impact of disease-modifying drugs such as hydroxychloroquine for osteoarthritis. Welcome, Dr. Vincent.
Thank you very much.
So, Dr. Vincent, the scientific community is moving away from the kind of wear and tear definition of arthritis that a lot of our patients subscribe to because of the increasing recognition of the inflammatory process in OA. Could you talk a little bit about that inflammatory process?
Yes, but I'd rather talk about the biological process in a more general way, because it's absolutely true that we're moving away from thinking of two cartilage surfaces just wearing down in the same way that a rubber tire would wear down on your car over time, because of course the chondrocytes, the cells that sit within the cartilage, are alive and they are exquisitely sensitive to their mechanical environment. So when they sense a change in the mechanical environment, they respond accordingly. Now, the inflammatory component of osteoarthritis, in my view, is one of the ways in which they respond to a hostile mechanical environment. And that triggers a number of inflammatory pathways inside the chondrocyte that drives genes that we associate with any inflammatory response, which would be similar to that which we see in rheumatoid arthritis and in other forms of arthritis. But it's completely driven by that mechanical load, and that's the key distinction in osteoarthritis. But mechanical load also does good things, and it drives a different sort of biological pathway as well, which tries to counteract that by promoting repair and regeneration of the articular cartilage. And I think that's often forgotten because these things need to be a balance within the cell. And it's really vital that we understand which components of the drivers, the mechanical stresses, are driving each of these, and whether we can boost one and suppress the other in order to try to repair our tissue and keep it as healthy and as strong as possible for as long as possible.
So when I hear mechanical load, I think like our patients, and I wonder, is that why physical activity or weight-bearing exercise or resistance training is a kind of positive mechanical load? Is that the case?
Yeah, I think that's exactly right. I think the right sort of load, sort of compressive load, is actually really good for the joint. And we know that because it releases a number of growth factors that are present in the matrix of cartilage, in the sort of packing material of cartilage. And those released growth factors that are bound to the matrix are able to promote that healthy cartilage, the sort of thick, healthy cartilage that you get if you do regular exercise. And the other real benefit of doing proper weight-bearing exercise of the joint is that it strengthens the muscles around joints. And so when you're walking on a joint, you're walking with a really well-supported joint that isn't sliding around on itself as it walks. And it's that sliding or shear stress that we think is triggering the mechaninflammation, which is the damaging part of the mechanical load.
So in terms of regular exercise, in your mind, are there any specific types of exercise that you would promote for people with osteoarthritis versus others, if we really want to focus on this positive mechanical load?
Well, I have to say that I think most of the advice that I give to patients is to any exercise is better than no exercise at all. And I would say that anything that builds up quadriceps muscles, for instance, or any muscles that surround particular joints, I'm talking about the knees predominantly here, but anything builds up the muscles across joints is really good for the joint. Weight loss, of course, goes with exercise, and that's also critically important. So anything that strengthens the joint, activity is generally good, both systemically and at the local factors in the joint. And I think the activities that might be less good for the joint might include things like doing a lot of shear stress, so really heavy weight lifting and going up and down sort of, lifts and so forth. and also, activities that you're not used to. So don't try running a marathon when you haven't trained for it. So make sure that you build up activity generally to strengthen those joints in order to protect them, and then you carry on doing extra exercise.
I see. So Doc, a lot of patients like me who have OA rely heavily on self-management therapies for OA, because of course there's so much concerns around extended use of pain relief medications, whether it's over-the-counter or prescription. So what can you tell us about what may be new or next with OA therapies?
So I think we've got to the stage where we've understood and we've learned so much about biology over the past 20 years that the sorts of therapies that are beginning to come into that transition phase from the preclinical, from the experimental, moving into patients for the first time, I think are the ones of the future. They're the ones that really we are going to see that really change the face of osteoarthritis. So I think that there are a number of agents that are in phase 2, phase 3 clinical trials that I think have promise in that regard. And these are interestingly ones that are not necessarily dampening inflammation, certainly not in the way that we know of from other disease areas. So I think we're moving away from thinking about osteoarthritis as being a more classical inflammatory disease where we can target the inflammatory cytokines, the inflammatory molecules that we have recognized through rheumatoid arthritis. And I think that there are two principal groups of therapies that we'll see being increasingly used in the future. One which is promoting the anabolic side, promoting the repair of cartilage through activating some of these pathways that I mentioned that are due to the release of growth factors in cartilage, trying to recapitulate that in order to see this regeneration of cartilage. And I think that is by far the most interesting and new observation that we've really come to in the past few years, not just from experimental studies, but also from looking at the genome-wide association studies in osteoarthritis. We see these repair pathways coming up again and again and again, and it's making us think very differently to how disease is really caused in osteoarthritis, that maybe it's not largely due to the inflammatory response, but maybe it's to do to a failure of repair response that predisposes some individuals to getting OA. So that's the main focus of my talk. Of course, there's still this very interesting area, neutralizing pain through nerve growth factor, which everybody will be familiar with. It's been discussed a lot over the past 2 to 3 years. Big phase 3 clinical studies looking at anti-nerve growth factor. Very disappointing news, both from the EMA and the FDA in the past year, which have not supported licensing this as a treatment for patients. And there are lots of reasons for that, but largely it's because of this concern of the risk factors associated with these treatments, with this relatively small number of individuals going on to develop rapidly progressive osteoarthritis on these treatments. So we hope that something can come out of that in order to somehow refine those treatments to reduce that risk profile, and then they still become a very interesting and important avenue for patients. But until that happens, I think at the moment my money is more on disease modification than it is for directly looking at pain. And my view, and it's not necessarily a majority view, is that if you really do build back cartilage, you will also impact pain in patients as well.
What timing in terms of the kind of more immediate horizon are we looking at, Dr. Vincent, or are we still decades away?
I don't think we're decades away, but unfortunately, these things just do seem to take an eternity to develop. And that's partly because osteoarthritis is such a difficult disease to do clinical trials in. It's still the case that we seem to have a lot of confusion about what the FDA want in terms of whether they need to see structural modification as well as symptom modification from the same drug. And I think that's quite challenging to deliver at the moment from a single trial. So I think all the different scientific areas of the osteoarthritis research community come together, need to come together, and are coming together in order to tackle this, because I think we need to think very carefully about design of clinical trials that enable us to have the power to detect clinical signals as well as disease modifying signals within the same studies. So I think that we're talking, I mean, I'm an optimist. You have to be, otherwise you wouldn't go into working with osteoarthritis, I think. But I would say that I would hope that we would see something that was licensed for patient use, certainly within the next 5 years, and certainly within the next 10. And I'd love to see it happen earlier than that, but I just know that there are hurdles along the way that slow these things down a lot.